This is Dr. Masud Mulgeta, radiologist, musculoskeletal radiology subspecialist, president of Radiologic Society of Ethiopia, and I work in Addis Ababa University, and I'm Health for the World Ethiopia chapter. Today we will be having Health for the World International Grand Rounds on elbow imaging. Our speaker being Roopa Ram, who is a professor of radiology, musculoskeletal division in the University of Arkansas for medical sciences, and Health for the World University of Arkansas chapter. I will right away leave the stage to our speaker, Roopa Ram. Our speaker, the stage is all yours.
Thank you so much, Dr. Mesvin, and thank you for the introduction as well. So what we'll do today is go through completely through the spectrum of imaging of elbow. Can everybody hear me okay and see me okay?
Yes, we can hear you.
Okay, awesome. Yes. So it'll be a lot of cases. I kept it more case-based considering the more trainees in the audience. So if there are questions at the end, I'll try and wrap up a few minutes early and we can take questions if there are any. So beginning with just sort of introduction to the elbow. We know the elbow is a very complex joint. It's truly actually 3 different articulations within one joint capsule. So we have the ulnotrochlear joint, which is like a hinge joint, the way it works. We have the proximal radioulnar joint, which mainly assists with rotational movement. And then we have radiocapitellar joint, which sort of does a hybrid function. So we're looking at 3 separate compartments, but all encapsulated within one anatomic capsule. And for anatomy, the way I like to think of elbow is if we know these 10 or 11 things, I think we're good with elbow. Elbow is one of the simpler joints compared to ankle, where we have, 28 ligaments themselves. The elbow is a rather simple joint to comprehend. So if we understand these 2 tendon origins, look at some tendon insertions, nerves and ligaments, that's kind of the basic anatomy for elbow. Of course, like in radiology, we use all modalities to image the elbow: X-ray, CT, ultrasound. Each of them has very specific uses in the elbow joint as well. But for purposes of today's talk, we'll delve more on MRI. Multiplanar MR, of course, is superior because of its high soft tissue resolution. We do imaging in multiple planes, and thankfully in the elbow, everything is somewhat anatomic in straight coronal, axial, sagittal. So if you imagine the axis between the medial and lateral epicondyles, the line that traverses through that is what determines the plane for elbow imaging. No angles or complex planning involved. We do a combination of proton density, fat suppressed T2, and at least one T1 weighted image for marrow signal evaluation with a small field of view imaging. Prone position is preferred. It's not always easy to be in that Superman position for a long time, but you do get good images and less artifact with this position. In our practice, we've also found that doing 3D imaging has been really helpful, especially with athletes where you're looking for very small findings. You need to reconstruct ligaments in their anatomic plane, do some MPRs and such. So we have found that 3D imaging has been really helpful. Same for MR arthrography. It's been excellent for detection of small osteochondral abnormalities, loose bodies within the joint, subtle ligamentous injuries, particularly in post-operative patients when you don't know if there is a re-tear or not. Distending the joint has been really helpful. And we do image for our athletes here up in the University of Arkansas. So these are elite athletes we're looking for very, very small findings on. So in all those, the arthrograms have really helped us as well. Moving on to some detailed anatomy, we'll start with 2 tendon origins. So these are just some schematics I took from the internet just to recap everyone's understanding of what the common extensor origin is. So here we see multiple components coming together to form the broad common extensor origin. You'll see the biggest contribution is from ECRB. So for orthopedic surgeons, this is the muscle that matters the most because this has the direct footprint insertion with smaller contributions from the extensor digitorum and ECU. The ECRL has a slightly higher footprint on the distal humerus. So at the epicondyle, largely the muscle ortho worries most about is the ECRB. And on MR images, this is how the normal tendon should look like. It should be black in signal, homogeneous, no fluid-like signal or intermediate signal on these proton density fat suppressed images between the tendon or bone or within the substance of the tendon itself. When the joint is not distended, it can be hard to distinguish the radial collateral ligament from the common extensor, but sometimes there's this thin sliver of fluid which helps us separate the two. One thing I'll say for the trainees too is get into the habit of seeing all these tendons and ligaments in multiple planes. Yes, there are certain planes which are optimal to see certain structures, but your knowledge of anatomy is incomplete if you cannot envision one particular structure in all different planes. So use different planes to your advantage. On the flexor side, similarly, we have multiple muscles that constitute the common flexor origin: palmaris longus, pronator teres and FCR at the top, and then the FDS and carpi ulnaris at the bottom. Again, a broad footprint. Same rules apply for the common flexor origin. You want to see a black homogeneous tendon attaching to bone, no fluid or intermediate signal, no bony changes. Contours of the epicondyles where the tendons attach should be smooth without remodeling or cystic changes. So those are some things to look for. So the other thing we start looking at is 3 tendon insertions, starting with the biceps tendon. A little bit about biceps anatomy. So biceps does have 2 heads, as we remember, the short head and the long head. So the short head is the one that's more active in flexion, and it occupies a larger area on the footprint and attaches slightly more anteriorly at the bicipital tuberosity. The long head attaches slightly posteriorly and provides the more stronger torque force, particularly in supination. So this is just a schematic again showing the 2 heads of the biceps. So the blue is the short head with the broader and anterior footprint. The red is the long head with the narrow and more posterior footprint. And origins, we know that the long head comes from the supraglenoid tubercle and the short head comes from the tip of the coracoid process. And knowing that there are 2 distinct heads is really important, because in elite athletes, we see a lot of partial biceps tears. In those situations, it really helps the surgeons to decide whether they should go for a repair or is this something that might heal on its own. 50% is generally taken as the cutoff. If it's a greater than 50% injury, they're more inclined to do a surgical repair. And in non-athletes, sometimes partial bundle tears may not always be operative. They may scar down on their own. So important to try and tease out the 2 heads if we can on imaging. And with that 3D imaging, we've definitely been able to pick up and call discrete bundle tears in the biceps as well. So just to show you what these look like on MR. So again, black tendon, homogeneous, attaching onto the radial tuberosity, seen in coronal and axial planes. Sagittal is another important plane. When you're seeing biceps pathology, it's really important to plan your sagittal images with a wider field of view, because sometimes the retraction can be very high. The tendon can go all the way up to the mid-arm or closer to the shoulder joint. So you may have to scan more like a humerus and not just a true elbow joint. So this is where involving and educating the technologists really helps, and sort of explaining to them why acquiring sagittal images and then axial images in 2 higher planes would be important for you to give information about retraction. The bicipital aponeurosis or the lacertus is this small fibroaponeurotic expansion. It right where the biceps delves into the joint, you'll see into the crease of the elbow, you'll see it give off this fibroaponeurotic expansion, which blends with the fascia of the pronator muscle on the medial side. So this is what is supposed to help the biceps tendon from retracting. So if you see a significantly retracted biceps tear, it almost always implies that the lacertus is also torn. It acts as a restraint to prevent retraction of the tendon. So this is another structure we need to talk about in our reports and specifically mention whether or not the lacertus is seen or it's torn. Brachialis is the next muscle we see. So at the same horizontal level that we see the radius attached onto the bicipital tuberosity, we see the brachialis muscle come attached to the ulnar, specifically to the coronoid process. It's also seen on sagittal images. Brachialis, remember, is a very important flexor at the elbow joint. So you kind of see biceps and brachialis in the same horizontal axial cuts. Triceps, again, slightly complicated anatomy. As the name says, it has 3 different heads. The long and the lateral heads start much higher in the humerus, and they unite to form a superficial tendon, which attaches to the olecranon. And more lower down, the medial head arises directly from the humeral shaft, and it has more of a muscular attachment directly onto the olecranon. And because it's a dual insertional anatomy, you can have separate injuries, slightly different clinical presentations. And in our practice, we have seen a lot of triceps ruptures actually involve that superficial component, which is combination of the long and lateral head. And less commonly, the deep medial head gets torn. So again, schematic showing the same thing, the long and lateral heads with the conjoint tendon and the shorter medial head arising from the distal humerus. Avulsion injuries are common with sudden forceful hyperextension. So look for bony fragments arising from the olecranon process where all the 3 heads come and attach together. So this is what triceps would look like on MR. Sagittal, again, is a good plane. Axial is good to quantify what percentage of fibers are torn. Same as biceps, if you have a highly retracted triceps tear, you may have to scan higher. So educating the technologists and getting the images checked is really important. Moving on to nerves. 3 nerves that are important at the elbow. First one is the ulnar nerve. It's the easiest one. We can all palpate it on ourselves. So it always sits behind the medial epicondyle. There's a thin ligament of os bone, which forms the roof of this cubital tunnel. And the floor of the cubital tunnel is formed by the posterior bundle of the UCL. So the nerve should always be like this. The retinaculum should be thin, the overlying subcutaneous soft tissues, the fat should be clean. There's no scarring around the nerve, no space occupying lesions or subluxation of the nerve. That's what we're looking for. Radial nerve you'll find in the groove between the brachialis and the brachioradialis. Here it is. More inferiorly, the nerve is going to divide into a superficial and a deep branch. Superficial is harder to see, but the deep branch dives in between the 2 heads of the supinator muscle, and it forms what's called the posterior interosseous nerve. This is the main innervator to the extensor muscles of the forearm. So this passes through this fibrotendinous arch called the arcade of Frosch. So in 30 to 40% of cases, there can be potential for impingement of the nerve as it passes through that sharp arcade of Frosch. So that can be a potential site of impingement. And then finally, we have median nerve, which traverses along with the brachial neurovascular bundle. More inferiorly, the median nerve is going to traverse between the 2 heads of the pronator teres, and that's where it can be prone to getting pronator teres syndrome, which can affect innervation of the flexor muscles. Distally, the median nerve continues as the anterior interosseous nerve, which innervates the flexor muscles of the forearm. So remember, PIN is a branch of the radial nerve, and AIN is a branch of the median nerve, and they innervate the extensor and flexor groups respectively. Finally, the ligaments around the elbow. The ulnar collateral ligament is probably the one most talked about, especially in athletes. We know that it has 3 distinct bundles, anterior, transverse, and posterior. Of these, the anterior bundle is the most important one for stability at the elbow joint. Anterior bundle tears are considered surgical in athletes most of the times. So in going from anterior to posterior, you'll see the different bundles come through. It's okay to have a little bit of signal underneath this posterior bundle attachment. It can have a little fan-shaped appearance with intermediate signal, as long as it's not fluid signal. Of course, you always correlate with history to make sure it's not a sprain, but that can be a pitfall when you evaluate these bundles. So be sure to carefully look at the architectural anatomy and then correlate with history as well. LUCL, which is the most important posterior restraint of the elbow, is another important structure. It's going to arise from the supinator crest of the ulna, traverse around the head and neck of the radius, and then blend with the LCL. Sometimes you can see the LUCL attached to its own little groove along the lateral epicondyle, but often it blends imperceptibly with fibers of the LUCL. So this is the most important posterior stabilizer of the elbow joint. And I'll show you cases later about what happens if there is an LUCL injury. And then we have RCL, which I showed you earlier, lives deep to the common extensor tendon. It's an important lateral stabilizer of the elbow joint. In non-joints, it can be really hard to see the RCL separately. But most of the times, if there's a little bit of fluid in the joint, you can end up seeing the RCL really nicely on coronal images. And then finally, most important ligament around the proximal radioulnar joint is the annular ligament. So this is the one we often see in kids with things like nursemaid elbow, when this ligament can be sprained or torn with sudden forceful pull on the arm. So this stabilizes the proximal radioulnar joint. We don't see problems with the annular ligament so much in the adult population as we do in pediatric, but nevertheless, it's an important stabilizer as well. So those are the anatomic structures, the three tendon origins, insertions, nerves, and ligaments. What I want to do next is go through cases. So we'll do cases kind of in sets of three different pathologies. So for the first group of cases, I want to emphasize about importance of joint effusion and some soft tissue structures around the elbow joint. In the next set of cases, we'll look at the tendons and ligaments. And in the last set of cases, we'll look at some nerve abnormalities. So this is a patient who fell onto elbow. And if there are trainees in the audience, you'll recognize the importance of fat pads on this one. So you do see a very elevated anterior fat pad, which we call the sail sign. And we see a visible posterior fat pad, which we're not normally supposed to see a posterior fat pad. And then when you look closely enough, you'll see a very subtle fracture of the neck of the radius. So if you see elbow joint effusion in a trauma patient, in an adult, most often it will be a radial head or neck fracture. In pediatric, you look for supracondylar fracture. If you don't see one, the classic teaching in radiology is that you always bring the patient back in 7 to 10 days. Most of the times, fracture lines will then declare themselves. Or if you're very sure there is a fracture, you're not seeing it on X-ray, on conventional views, be sure to get specific views called radial head views, where the tube is angulated at between 30 to 45 degrees. So there is no overlap. The radial head neck junction gets elongated and you're able to see subtle fractures. If despite all that you're not able to see a fracture, in athletes, they do CT scans because the time to return to play for them depends on whether there is a displaced fracture or not and how much immobilization is needed. But most of the times, if you do follow-up X-rays, you will find these fractures. Just showing you a few more examples. This one is also subtle. We do see an elevated anterior fat pad, and there's a very small line here. Some of these are easily missable when you're going through a big stack of X-rays. But then, like I said, in 7 to 10 days, most of these fractures declare themselves. So here we see that same fracture with intra-articular extension. It's a little more displaced, much easy to call it now on X-rays. So if you're not sure, think about obtaining those radial head views or going on to advanced cross-sectional imaging. Here's another one. Patient fell onto their elbow. We know of the terrible triad in the knee, but remember there is a terrible triad in the elbow as well, which is posterior dislocation, fracture of the coronoid process, and fracture of the radial head. As with shoulder joints, it may be very hard to see all these fractures when the joint is in dislocation. So on post-reduction views is where you'll see a fracture through the neck of the radius here, and then this irregularity through the tip of the coronoid process, which is consistent with a displaced fracture as well. And we see big elevated fat pads. And when this happens, the LUCL, or the lateral ulnar collateral ligament, is the ligament that most often gets torn. So these sometimes have, if they don't scar down well, may need surgical fixation of LUCL. If not done in time, LUCL injuries can be the start of what's known as posterolateral rotatory instability. We'll talk a little bit more about that. But remember that if you have a posterior dislocation of the elbow, most often the LUCL is injured, and in elite athletes, it may need surgical fixation. We see a bunch of our athletes who get ligamentous reconstruction for LUCL injuries because the joint becomes unstable, and that is something they cannot afford being of that athletic caliber. Next case is a young patient with elbow pain. And what we see here is very disproportionate and early destruction of the joint. The articular surfaces look very irregular. Here's that elevated posterior fat pad again, large elbow joint effusion. We see some bony debris along the anterior joint recess, significant remodeling and erosion of the radial head. So when we start thinking about causes like this, always a good idea to examine the contralateral side or evaluate some of the smaller joints. So this person had known history of juvenile idiopathic arthritis and then ended up with premature secondary arthritis in the elbow joint. So elbow is one of those joints which can be affected with systemic diseases like rheumatoid arthritis, juvenile idiopathic arthritis. So be on the lookout when you see younger patients with unexplained premature early arthritis. Here's another example. This was a very athletic patient who had been having limited range of motion in the elbow. We did x-rays. The x-rays only showed joint effusions with elevated fat pads. Again, did not see discrete erosions at the time. So we kept looking for osteochondral abnormality, osteochondritis, some kind of ligamentous injury, because he would do a lot of throwing sports. The concern mainly was for sports related injuries, but then when we did an MRI, we found this large complex joint effusion with synovitis, lots of marginal bone marrow edema wherever the synovium attaches. So these findings actually raise suspicion for some underlying inflammatory arthritis, which was not on the radar because he was more of a sports like person, but it can happen. And workup wise, this ended up being some other inflammatory arthritis spectrum as well. So even in athletic people, remember to keep these arthritides in the differential. It can happen even though we put it lesser on our differential. This was one of those variant cases. This is an older person. They have known rheumatoid arthritis. And again, on x-rays, what we see is soft tissue fullness in the olecranon bursa. No obvious erosions seen on x-ray, not even a very big effusion, but then MR shows complex joint effusion with lots of synovitis. We again see this marginal bone marrow edema, a lot of soft tissue swelling around the joint itself, and the soft tissue thickening in the expected location of the olecranon bursa, which is either complex bursitis, or many times patients with rheumatoid can get these cutaneous nodules as well along the along bony prominences. So this could have been a cutaneous rheumatoid nodule as well. So elbow is also a site where rheumatoid likes to be involved. So look for symmetry, look for small joint involvement. This person also had fluid in there around their biceps tendon sheath and in the bicipitoradial bursa. And if you look within the fluid, there are these small bodies, which we call rice bodies, which are fairly typically seen with rheumatoid or in some atypical mycobacterial infections and such. So full-blown spectrum of rheumatoid seen around the elbow joint. Here's another relatively young patient with early joint destruction. Here we see subchondral cystic changes, both sides of the joint. There is an effusion. And when you look on the T1s, you'll see that all the articular surfaces appear somewhat flared out. So this is a patient with known history of chronic hemophilia. So they bleed repeatedly into the joint. And because of the hemosiderin and the pressure related erosions, the cartilage gets destroyed and they end up with premature arthritis. When you look at x-rays on this patient, you might see a little bit of a dense joint effusion. You will see the flared appearance of all the epiphysis from all the hyperemia and the blood products that cause remodeling around the articular surfaces. And this is again for trainees, this is something they like to show in boards and such, where they'll show you a knee x-ray with widening of the intercondylar notch. So all these findings together go with some sort of long-standing chronic hemophiliac arthropathy causing early joint destructive changes. Next case is fall and swelling around the elbow. So here we see lobulated soft tissue swelling in the expected location of the olecranon bursa. We see some soft tissue fullness around the triceps as well. And then because this was somewhat non-resolving, this patient actually got an MRI, and what we see is a nice organized collection in the olecranon bursa. If you see, it has a nice T2 hypointense rim around it, telling us that it may even have been a hemorrhagic bursitis. So chronic olecranon bursitis can happen with friction-related changes, or it can be acute in the post-traumatic setting and can present with a lobulated mass in the back of the elbow. This is another one where the olecranon bursa actually got infected. So you can see thick nodular enhancement around the bursa, some cellulitis and the surrounding soft tissues. So watch out for secondary signs of infection. This is another one who had a shear injury, fell off of a tree and caught themselves. So here we see a fluid hematocrit level in the expected location of the olecranon bursa. So in the setting of a shear injury, these are in the moral level lesion spectrum, which is just delamination and accumulation of lymphatic fluid in those subfascial layers. And then this one also had a little bit of a triceps muscle strain. So common location since it's over a bony prominence. And then this was a typical history of gout. So here we see this cloud-like density within the olecranon bursa, very lobulated soft tissue prominence. And on both T1 and T2 weighted images, gout is predominantly low in signal. So these are gouty tophi. And when these start eroding into the bone, that's when you will get those typical overhanging margins. So these are some pathologic conditions where you'll see an elbow effusion or you'll see changes in and around the olecranon bursa. So moving on to cases that show us tendon pathology or ligamentous injury. So this was a patient who fell off a tree and heard a pop. So what we see here is significant soft tissue swelling where we expect the triceps tendon. There is a small bony fragment embedded in the soft tissues as well. Don't know if any of the olecranon may have been the donor site. So based on X-ray, you should have a very high index of suspicion for a triceps injury. And when we did MRI on this patient, what we see is complete rupture of the triceps tendon. So it's very differentially retracted. And here you can see hardly any fibers attached to the footprint. So this was a complete tear involving both those superficial and deep components, which means it involved all three heads of the triceps tendon, significant strains of the muscle going all the way up to the mid-arm, a lot of subcutaneous soft tissue edema, traumatic fluid in and around the olecranon bursa. So full spectrum of triceps injury. So look carefully at the plain films. You should not have that much soft tissue fullness where the triceps attaches. The fat posterior to the triceps attachment should look clean. So once you don't see those changes on X-ray, you can suggest MR and then you'll be fully able to evaluate the extent of tendon injury. Another case sort of in the anterior compartment. This one was weightlifting and heard a pop. So what we see here is completely retracted torn biceps tendon, again differentially retracted. So this is where I told you you have to scan higher up. You may have to get these patients out of the elbow coil sometimes if the imaging doesn't reach up to where you see the normal tendon. So here the retraction is almost up to the level of the myotendinous junction. We see significant muscle strain. So sagittal is good to measure retraction and tell the surgeon till where the tendon is retracted. This is common, especially in weightlifters who use anabolic steroids, which actually in the long term can cause tendon weakening. So important to image the full extent of these tears. And like I said, if the lacertus or the bicipital aponeurosis is also torn, the tendon can significantly retract all the way, and patients can come to you with a swollen blue upper arm that's sometimes called a PLRI sign. So you'll have an obvious deformity in the region of the mid-arm. So give them the extent of retraction. Make sure you get sagittal and axial images which show you the healthy edge of the tendon. One other entity or one other imaging plane they talk about for biceps is what is known as the FABS view. So it's flexion at the elbow, abduction of the shoulder, and supination at the elbow. So that is supposed to remove all the obliquity in the tendon and make the tendon have a more tense appearance. And you can see the entire length of the tendon in one shot. So this is again another example of a retracted tear. We know the lacertus will definitely be abnormal because the tendon is retracted all the way to the myotendinous junction. This is how that FABS view is done. So here you see the tendon in its entire length in one go. So this is a special view you can employ. Although with the 3D isotropic imaging now, we don't really need to do this. We're able to reconstruct the 3D images and make it look like this without actually acquiring this in a special plane. So it's decreased our scan time. It's given us more confidence to call partial tears and to reconstruct the tendon in its anatomic plane. Then moving on to medial and lateral epicondylitis spectrum. So this is a patient with lateral sided elbow pain. What we see here is thickening of the common extensor tendon. As an internal reference, you have the common flexor tendon on the other side, which shows the normal black signal. So here we see a very thick tendon, and we actually see fluid signal along the depth of the tendon. So it's always good to quantify this and say, is it less than 50% or more than 50%? Again, with that cutoff being the decision point where ortho will say this is where we need to go in and repair this patient. So this is consistent with tendinosis and partial tear. So once you start seeing bony changes as well, it will go into that full-blown extensor tendinopathy or lateral epicondylitis spectrum. So like I said earlier, be sure to see these tendons in all planes. I find sagittal and axial both really helpful to see these tendons. The middle image here is comparison of a normal common extensor footprint. And here we have fluid-like signal because there is a tear at this common extensor footprint. Same thing seen on axial images. So a little bit more about the lateral epicondylitis spectrum. So this is a repetitive varus stress injury. It's first described in tennis players, so they call it tennis elbow, but really any throwing sport or activity where you have repeated varus stress to the joint can cause this. So the basic mechanism is there is distraction on the lateral side and compression on the medial side. So that can end up in a spectrum of injuries. I showed you a tear at the footprint. This is more extensive where the tendon has gone retracted into the upper forearm. So the ECRB is the one that most often retracts. So these are what we call delamination injuries. You can see the thickened RCL here, which remains attached, but there's no real common extensor tendon at the footprint. It's all come down. So mentioning the extent of retraction in these definitely helps the surgeon. Sometimes they may do an open repair instead of an arthroscopic repair. So that's when knowing retraction also helps. And in chronic cases, there can even be bony ossicle formation, which can sometimes cause irritation along the lateral aspect of the elbow or limitation of range of motion. So they may have to go and remove this ossicle even. So this is in that full-blown epicondylitis spectrum because we're seeing bony changes as well, in addition to tendon tear. And many times, because they have sort of a common footprint, you will see common extensor tears also have lateral collateral ligament tears or lateral ulnar collateral ligament tears. Approximately 40 to 50% of times, high-grade common extensor tears can have associated LCL or LUCL injuries as well. So here we see very high-grade tear. Neither the RCL nor the LUCL is attaching, so they are also most likely completely torn. And then here's an example of a more proximal LUCL tear. So this is that supinator crest of the ulna where LUCL is supposed to attach like a band. So here we just see these wispy strands of tissue, no real tight ligament attachment. We can kind of follow the ligament from here up, but the proximal attachment is definitely sprained and partially torn at its ulnar insertion. And we see plenty of edema around the elbow joint, strains of these muscles. So most likely this is a patient who had a posterior dislocation, tore their LUCL, and then now has come with more signs of instability. So tear of the LUCL is the beginning of what is known as posterolateral rotatory instability. So there is an imaginary circle around the elbow joint. It's called the Hori circle. So once you disrupt the circle, there's a very predictable order in which the ligaments tear. And any of these causes really can be inciting causes for PLRI. So there is a staging in which PLRI goes through. And what it is increasing perching of the ulna till in stage 3, finally, everything is frankly dislocated. And I like this cartoon. This is from a recent radiographics article. If someone is interested, I can share the link for this later. So it shows the stepwise progression of PLRI where it starts with LUCL, then progresses along the RCL, and approximately 50% of anterior posterior capsules. Then in stage 3, progression is more along the posterior capsule. Now you have involvement of the UCL as well. And then in stage 3B, there's circumferential tear of the capsule, and what started as a lateral sided injury eventually ends up with complete tears of both the bundles of the UCL as well. So it's a predictable order in which these ligaments tear, and eventually the elbow is rendered quite unstable. So important to recognize LUCL injuries so as to prevent patients from developing long-term posterolateral rotatory instability, which is why in athletes they have a low threshold to repair them, so that we don't end up with MCL tears, which can then be detrimental to their throwing careers. So just like how we saw lateral epicondylitis, where the tension was on the lateral, compression was on medial, in medial epicondylitis, it's the opposite. So this is a repeated valgus stress, which means the tension is on the medial side, the compression is on the lateral side. Classic athletes are pitchers who pitch and hyperextend and put this ligament into valgus all the time. So in throwing athletes, there is really a big spectrum of injuries which happen on the medial side of the elbow joint. So most common or minor ones are flexopronator strains. Then of course the UCL starts getting into sprains and tears. And because of the shearing, you do get into these ulnar traction spurs or VEO osteophytes, as we call them, valgus extension overload osteophytes. And then eventually there can be problems with the ulnar nerve as well, with subluxation or ulnar neuritis from repeated stretch injury. So we'll look at some of the reasons. And again, this is a schematic from that same radiographics article, which shows us why these things happen in valgus stress. So you stress the bundle, anterior bundle of the UCL, which is the most important one for stability. So with increasing tension on the medial side, you cause increased compression on the lateral side, which means these two bones, the capitulum and the radial head, are at risk of developing osteochondral abnormalities. And then finally, with that rotary and shear type force, this part of the olecranon undergoes lot of compression with the humerus, and you develop this very typical valgus extension overload osteophyte along the posterior medial olecranon. So this is the, again, somewhat predictable order in which valgus stress goes through. So just to show you examples, so here's the medial side. Here we see strain of this flexopronator muscle group. And on those sagittal images, there's a nice interstitial tear of the common flexor origin. Here's more drastic examples with retraction. We don't see any tendon attached to the footprint, very significantly retracted common flexor origin tear in this patient. Same tear as we can see on sagittal images with the retraction coming all the way till here. And then this one has a nice periligamentous edema around the UCL, so probably a sprain of the UCL and definitely muscle signal within that flexopronator muscle group in a baseball playing athlete. So these are some injuries along the throwing athlete spectrum. Here's another example. Here's a somewhat high-grade tear of the proximal UCL, bone marrow edema, where it attaches to the humerus, and then at least a grade 1, if not a grade 2 strain of the pronator muscle, and some radial head contusions as well. And then here's an example of a distal UCL tear. So we see edema at the coronoid process. We see a break or discontinuity where the UCL should attach to that coronoid process. Some signal irregularity, attenuation of the ligament itself. For small tears like this is where arthrography really helps. If we are looking for very small tears and we have a non-distended joint, we may not be able to see small areas of attenuation and partial tears. So if you have an elite athlete, you're looking for a UCL tear, definitely consider getting an arthrogram. And if they've already had a repair, then also definitely consider following it up with an arthrogram to see if there is a re-tear or not. So UCL repair, as we know, they call it the Tommy John surgery after the pitcher who underwent the first successful treatment. What they do is they split the palmaris longus, typically use it as a graft material. Most of these patients can have ulnar nerve problems as well. So sometimes they do either a cutaneous or a submuscular transposition of the ulnar nerve. So here's the UCL. You see susceptibility artifact, thickened. So as you can see, if there are small tears of this and if you don't have fluid distension of the joint, it's very hard to call re-tear or re-injury. So arthrograms are really important in that setting. And here's that VEO osteophyte I was talking about. So here we see signs of UCL injury where we see hypertrophy at the sublime tubercle. Here's an ossicle at the proximal attachment. So we know this person has had UCL injury. And here's that tiny VEO osteophyte, which forms mainly because of the shear stresses that happen between the olecranon and the humerus. And we have found that it's very easy to miss these small osteophytes on MRI. So here's where thin section CT scan images actually really help in picking up these small osteophytes. And these osteophytes are really symptomatic. These athletes do get very severe sharp pain. So we've had several of our surgeons who have told us this is something specifically they are looking for. And that's where having conversations with your sports medicine people, with the orthopedic surgeons is really important, because these are very small findings. Unless you know you're looking for them, it's easy to miss. So thin section CT is actually really helpful to pick these up. And here's another example of a very small VO osteophyte. So we saw this small loose body on the X-ray. We were not sure where it was. And history-wise, they were very suspicious. It's a detached VO osteophyte. So we did an arthrogram. So with good contrast distension, you can see that small bony fragment here, which we saw on the X-ray as well. And this one actually got arthroscopy and removal of this VO osteophyte. And here you can see sequelae of UCL injury. Their UCL attachment looks very thick and scarred. Even distally, there's a little edema in the sublime tubercle. So these can be small, subtle injuries. So be on the lookout for them in throwing athletes. In very young throwing athletes, something else that can happen is what's called little league elbow, where you see the apophysis take the brunt of all the pitching and the valgus stress. So because the bony mineralization at the apophysis is not yet complete, you'll see the apophysis develop fragmentation. In late stages, there can be sclerosis, there can be fluid-like signal at the apophysis. Plain films are good to show you kind of that asymmetric hypertrophy along the medial epicondylar apophysis. In kids, everything can look strange because of the way the ossification centers fuse. So it's not a bad idea to get contralateral images of the non-pitching arm to see how the ossification center or the apophysis looks different. But if you start seeing this fluid-like cleft, that can be worrisome. And in acute cases, there can even be a sudden avulsion of that whole medial epicondyle. So in very young pitching athletes, this is definitely something to look for in what is called as the little league elbow spectrum. Similarly, in young throwing athletes, something also to look for would be osteochondral abnormalities in the capitellum. So this patient came with inability to completely flex the elbow. They felt like something was locking or catching. What we see is a small bony fragment here in the anterior joint recess. When you look on X-rays, there's not a real obvious osteochondral abnormality. But on MR, we were able to see that small bony fragment here, which has now migrated to the posterior joint recess. And when you look on T1s, there's definitely articular surface irregularity of the entire capitellum. So most likely this was the donor site. So these can start as small loose bodies, but the synovium just feeds it and they become larger with time and they become more symptomatic. They may not remember the exact time of injury when this happened. At the time, it may just have been minor elbow pain. But as these bodies grow, they can become more symptomatic. So here's again a thin section CT on that same patient where we see subchondral sclerosis and confirming that this is the donor site. So OCD of the capitellum is again something that you see with repeated microstress in throwing athletes. It's slightly different from Panner's disease. Panner's disease is more often a self-limiting osteochondral abnormality that happens in very young kids, 6 to 8 years. This is more in adolescents. So in OCD, it's important to tell them whether there's a stable or unstable fragment, and that may determine whether they need arthroscopic surgery to remove this fragment. So for the tendons, as a recap, I just want to say that the varus stress results in lateral epicondylitis. And remember to look for LCL and LUCL tears with high-grade common extensor tears. And LUCL is the start of PLRI, which progresses circumferentially and ends up with tear of the UCL. For valgus stress, you have medial epicondylitis, and here anterior bundle of the UCL is the one at most risk, and that small VO osteophyte can result from excessive shear injury. And then finally, we look at some cases where nerves are abnormal. So here's a nearly normal looking elbow, but when you look closely, there is this soft tissue with same signal as the muscle here. So this is the normal anconeus on the lateral side. This is the accessory anconeus. So remember what I said about the ulnar nerve being behind the medial epicondyle with nothing but the thin retinaculum on top. So this is very abnormal. This can cause impingement of the ulnar nerve. So this is called an accessory anconeus or anconeus epitrochlearis. We see it quite a few times a year. And in athletes or those who use their elbow a lot, it can be a source of cubital tunnel syndrome, where you do get ulnar nerve signal changes and they may need debridement or resection of that accessory muscle. Some other causes for cubital tunnel syndrome: anything that causes thickening of that ligament of Osborn, repetitive valgus stress. You will see high signal in the ulnar nerve. In late cases, the ulnar nerve can start subluxing as well. There can be UCL tears with scarring, which can cause impingement of the nerve. And in long-standing cases, you will end up with ulnar claw hand, which will affect the 1.5 digits at the hand. So some examples of ulnar neuritis: normal ulnar nerve should not be as bright as the vessels when you see them on fat suppressed T2 weighted images. So here we see this cord-like appearance of the ulnar nerve. Here we see the speckled appearance of the more proximal fibers with high signal nearly matching that of the vessels in the image, and we see a very thick Osborn ligament on T1 weighted images. So there's also a little risk of subluxation. This in later stages can be what we call as snapping elbow, where the ulnar nerve actually goes out of its groove, and patients can be very, very symptomatic. So ulnar neuritis, look for this in pitching athletes. This one was interesting. So evaluate bony abnormality. So we see two bony abnormalities. So this is a well-corticated ossicle here, maybe old UCL injury or a flexor injury. But what we see here is a supracondylar spur. This is typically always about 4 to 5 centimeters above the joint. And unlike osteochondromas, which point away from the joint, supposedly these point toward the joint. So it's a vestigial structure, but what it is close to is the median nerve, which it can cause direct compression of. So sometimes if the spur is causing symptoms, they may have to go in and resect this spur so patients don't have median nerve compression. So just a recap of anatomy. So this is the same spur which, when bridged with the medial epicondyle with the Struthers ligament, this is where in fetal life, supposedly the brachial artery and the median nerve course through. So one or both of these structures can be at risk of impingement if the spur persists. And more inferiorly, this is where median nerve dives between the two heads of the pronator, and you can get a little bit of pronator teres syndrome as well with flexion problems in the forearm. So if you see a supracondylar spur, be sure to check if the patient has median nerve symptoms, and then MRI will help you decide if the spur is symptomatic or if the cause of impingement is more distal somewhere to the elbow joint. And then this is a case to illustrate the importance of the posterior interosseous nerve. What we see here is edema-like signal involving the entire supinator muscle. We know that the deep branch of the radial nerve is who supplies the supinator muscle. So this must be some sort of injury to the posterior interosseous nerve. Like I said earlier, there are several sites of impingement of the posterior interosseous nerve. The most common one is here at the arcade of Frosch, which is a fibrotendinous band-like area where the radial nerve can get compressed. Another site is deep in the mid-forearm between the two heads of the supinator. The nerve can get compressed. You will see many practitioners do ultrasound-guided injections of the PIN in this location. And most often this will present as extensor compartment abnormality in the forearm. So very amenable to treatment under ultrasound guidance if we are able to identify the nerve. And then finally, we are in the era of joint replacement. We see so many of these every day. So just for completeness sake, I just wanted to show you examples of elbow prosthesis. So these are semi-constrained prosthesis. More often we see the ulnar component fail So here we see posterior tracking of the tip of the ulnar stem, large amount of lucency at the bone cement interface of the ulnar stem. Most of the times the radial head has been resected for either bad trauma or arthritis. And then here's an extreme example where this actually caused a sort of a pathologic fracture through the distal humerus. We see high density joint effusion, small high density debris, which sometimes can even be small flecks of metal. So this is all in the adverse local tissue reaction spectrum. We see it not infrequently around elbow joints. So when you're evaluating these prostheses, be sure to look for early signs of lucency, especially around the ulnar component. So as a summary, knowing complex muscle anatomy and sites of nerve impingement are important in the elbow. Fat pads are our friend in the setting of trauma. We should definitely look for a fracture. If there is no trauma, think about any of the arthropathies or crystal deposition diseases. Arthrograms, like I said, are good to detect small osteochondral abnormalities, re-tears in post-operative patients. And in the epicondylitis spectrum, be sure to look for additional LCL, LUCL injuries. And throwing athletes have a big spectrum of injuries. So look at each and every structure along the medial side of the elbow in a throwing athlete. You will find one or more of them are always abnormal. And then if you're imaging biceps or even triceps tears, be sure to have a good field of view so you're able to follow the entire extent of the tear and then see the healthy edge of the tendon at the distal end. So that's a lot of elbow cases. I want to thank you for your time and attention. We have a few minutes left. If there are questions, I'll be happy to take some.
Thank you, Roopa Ram. I really thank you for speaking on this topic, and I would like to thank Health for the World coordinators, including Dr. Amal, Dr. Ram, Brava, and others. We have to take some notes, including some of the things that we always tell to our students and seniors, including even in the athletic patient, don't undermine the possibility of non-athletic injuries. This is a great take-off message for the attendees. I guess as we always see or usually see cases of non-athletic abnormalities in an athlete. So that's a good point. One of the good points that was raised. The other is elbow involvement of Olecranon process. Usually, as you know, aggregates in gout are commonly accumulated in the Olecranon process. So there's a trend that usually when the region of the Olecranon processes has soft tissue swelling, edema or something, there is a trend to take into gout. So considering the rheumatoid nodules and other possibilities is a great take-home message in my opinion. The other is intrabursal hemorrhage versus bursitis. Usually, if people see fluid inside the bursa, there is a trend to call it bursitis. So intrabursal hemorrhages are also common due to lots of things. The other take-home message that I took was level of scanning in elbow. Usually, as you clearly showed us, level of scanning sometimes has to be way above the levels of the elbow as injuries, or sometimes way below the elbow as injuries of tendons can have retractions way above from elbow and below. And that's a really good take-home message in my opinion as well. The other is the significance of lateral ulnar collateral ligament injuries, especially in which is a devastating cause of posterolateral rotatory instability of the elbow. So always please don't undermine the value of lateral ulnar collateral ligament in athletic patients. That's also one of the, almost everything is cool, and that's one of the nice take-home message. Saying this, I will go to questions. I have you have two questions so far. So the first is, do you consider distal biceps injuries as, when do you consider it as partial or as complete? If long head is torn, do you consider it as partial or only long head or only short head is torn? Do you consider it as a partial or complete? That's one of the question.
I know I've asked this question to my elbow surgeons, and they say 50% is their cutoff, whether it involves whichever. 50% of the total is surgical in an athlete.
Thank you so much for answering, Dr. Ram. I think we have another question. Is a complete UCL tear obligatory in elbow dislocation?
Not necessarily. We see high-grade sprains. LUCL is the one that is almost always torn. UCL, not necessarily.
Thank you. And one more question. Can we use open MRI 0.3T for elbow imaging?
Low resolution, but for big picture, yes. If you're looking for where the biceps is retracted, yes. If you're looking for a small bundle tear, no. But yes.
Thank you. Thank you so much for the wonderful session, Dr. Ram.
No problem. Yes, pleasure to be here. There's one question I see in this chat which says, could arcade of Frosch cause triceps muscle
just
atrophy?
another
I have a
one
patient with
question.
forearm extensor muscle atrophy. Unusual because I don't think so. Because it's by the time the radial nerve has come to arcade of Frosch, it should have already innervated the triceps in the upper arm. Dr. Mespin, anything you want to add to that?
I guess that's the answer. So I don't think it needs more explanation.
Yeah, I have not seen it. Unless there is a variant where the triceps didn't get innervated and it's a low takeoff of the radial, and that is what is getting impinged at the Frosch. Uncommon.
Yeah, thanks a lot. That was a nice presentation. So we are running out of
One more.
time.
Yes. Okay.
We have
Can we
Ghana
go?
classrooms here. Anybody from Ghana classrooms, if you have any questions, please feel free to ask. Dr. Ram can address.
Nothing.
Yeah.
Okay. Thank you, everyone. Have a good day wherever you are. Nice to see everyone.